Yeah, I think that mental disorder is so conceptual. Even just the idea of what a mind is. I mean, it's a philosophical construct.
This is the Thinking Mind podcast.
I usually start with some kind of question about my interviewee's background. I think it's really rare to actually carve out a space in our lives now where we can actually reflect on why we've made the choices that we've made or gone into a certain direction, even though people might know that psychiatry has things built into it, like, for example, supervision sessions or things along those lines. So often that's co-opted by the need to provide a service and to make sure, quality control and things along those lines. I almost feel like we've lost the apprenticeship relationship between sort of the teacher and the student, where it's a bit more, it allows a space for kind of informal reflection. And I wonder how you think about the choices you've made career-wise, about, how you were drawn to the things that interest you.
So I can tell you truthfully that I have no idea why I became a doctor. I don't remember feeling particularly interested in either, I guess. I don't think I was drawn to this idea of, say, being a healer or a carer in some sort of way. Not to say that I'm not caring or not interested in helping people, but I didn't sort of feel a vocation. Nor did I feel that I was sort of, particularly moved by sciences, as interesting as I found them. I was quite interested in humanities. I thought that I might do English at university. But for a variety of reasons, and the main one, I think, just being a bit daft, really, when I was sort of 17 or 18, I ended up applying for medical school because I think I'd done science A-levels and I was a good communicator, and everybody around me was like, why don't you be a doctor? That's going to be a great career.
It seemed like the right thing.
Yeah. And I thought, well, I guess I could go to London. That would be quite fun. And so I applied for medical school and I went to UCL. And I think I sort of struggled to find my home within a medical school training. There were things that certainly interested me, but I sort of wasn't sure I'd really made the right choice. I couldn't imagine myself being a surgeon, although I have to say now, 20 years down the line, I sort of feel like, having done a lot of medicine, I could turn my hand to any of these things. I don't mean I can go operating on people, but that, that I can see the appeal of all of these things now, the craftsmanship of surgery and that sort of thing. But at the time, it didn't really draw me, and neither did being a GP or a hospital physician. But I think I had this idea about psychiatry, even though I didn't really know anything about it. And I definitely remember when I was very young, being interested in the idea of Freud, even though I knew nothing about him. Just the idea of unconscious forces, or being interested in what it is that makes a person who they are. And I think that's what drew me to being interested in novels, or even, in a way, being interested in doing English at university. What is it that makes what is this complex, all these complex factors that makes a character who they are and turns out to be their destiny and this sort of thing. And so I had some quite good psychiatry rotations at UCL. And I also did the medical student psychotherapy scheme there, where I had a very complicated patient, probably far too complicated for a junior doctor, let alone a medical student, I think, but I found it really interesting, and I found the supervision incredibly interesting. And so I thought, once I completed medical school and had done my 2 years as a house officer, or my 1 year as a house officer as it was then, and my year of SHO jobs, I thought, I'm going to do psychiatry, and if I don't like psychiatry, I'm going to do something else.
Something outside of medicine?
Something outside of medicine, yeah. And I applied to the Maudsley, and I got in and I started the training rotation. And not only did I find that I really loved it, actually, and thrived, But I met a bunch of other junior doctors, nurses, consultants, people who I felt were like me, who had similar sorts of stories, who had other kind of interests, who were interested in the medical model, but could see that being a doctor was an awful lot more than that. And that's not to say that people in general medicine don't have that view, because actually they do. And when you work with good doctors, they're good doctors. They have great bedside manners, they have great understanding of people's character, the interpersonal environment, the family environment that they inhabit, what symptoms might mean. You know, it becomes very hard not to... If you're going to be good at it, it's very hard to be good at it without having some reference to those kind of things. So that's in no way to diminish the kind of skills that they have. But I guess psychiatry rendered it quite explicit for me at quite a young age, before I was experienced enough to see that lots of good doctors had these skills.
So there's something there about maybe when you started working in mental health services, you achieved the kind of cohesion with the people that were around you, which perhaps you didn't have at medical school.
Yeah, I felt at home amongst the people. They felt like people who were like me in some sort of way. Although I had a lot of friends from medical school, there was something about our journeys that had been somewhat similar.
Yes, there's something about people not quite fitting in.
Yeah.
And I think psychiatry tends to attract those kinds of personalities, people who are perhaps maybe a bit too open-minded, people who are quite drawn to things which are ambiguous rather than things that tend to fall within very sort of tight boxes that might attract people to more conventional medicine.
I think that's right, and I'm afraid that this is like quoting a statistic that you haven't got the source for, and this may be a fantasy of mine or a fantasy memory of mine. But I have a memory of somebody alerting me to the fact that it has previously been the case that a lot of people who entered medicine late or postgraduates, a higher proportion of them ended up in psychiatry. And that just didn't surprise me, that people had done other things, maybe kind of philosophy degrees or humanities or psychology, thought actually I would like to be a doctor, gone into that, and then found that psychiatry was the right home for them. And I think there is a bit of a less of an opportunity to have a meandering journey before you go into medical school these days. Yeah. But I think in previous years it was a bit more the case that people did other things and had all of these different kinds of journeys.
Yeah, and I think there's some of perhaps the more elusive and subtle good points about being a psychiatrist are perhaps more obvious to people who are older and more mature, particularly the comfort with contradicting ideas and the ability to hold contradicting ideas simultaneously, and the ability to tolerate uncertainty. Yeah, I think are pretty essential.
Yeah, and something about managing ambiguity. Something that I think is the skill of maybe somebody who's a bit more mature that's quite useful in psychiatry is the ability sometimes to do nothing, to watch and wait, and not be reactive, and see what emerges, actually, how the picture develops. I think that medicine, by its nature, is quite interventionist. So, someone comes with a problem and you want to fix it, whether that's with a prescription pad or with some sort of, investigative procedure. And so it's very hard, actually, not to jump in and do something. And it takes a lot of experience and maturity, and that doesn't have to be necessarily within the profession, There's also no doubt, although I am not yet, but being a parent helps in some sort of way as well, because there are skills that are involved in that are very much involved in sort of thinking about psychiatry, thinking about how you help people manage anxiety, how you contain difficult feelings that you allow to be projected into you, and that you help people do something with, and that you hand back to them in a way that becomes a bit more manageable or digestible.
Yes, and to realize that often, you mentioned unconscious forces earlier, to realize often that perhaps the inclination to intervene is often just as much to manage one's own anxiety than it is to help the patient.
Definitely. And that you may not have the answer.
Yeah.
There may not be an answer. The symptoms and the life story and the enormous complexity that's in front of you, it may not have an easy formulation, and actually to create an easy formulation is what would be the word isn't fitting actually to the magnitude of the importance it has to that person who's brought you those difficulties. And that actually just you bearing witness to them and hearing them and really listening and thinking about them
carries therapeutic benefit.
Carries a large therapeutic benefit, absolutely.
So then did you find the transition from general medicine to psychiatry quite a smooth one? Did you face any challenges, any stigma from friends or family, from colleagues, things along those lines?
I didn't, but I think part of that is because I wasn't particularly I didn't really have an identity change in some sort of way. I wasn't particularly identified with being a general medic in some sort of way, and doing these sorts of things, and managing all of these different medical conditions. Of course, I did all of those things while I was a junior doctor, but I didn't make any secret about the fact that I was probably going to go on and train to be a psychiatrist. And it was certainly the case when I was a house officer that people would say to me, "Well, are you sure you want to do that?" There were sort of preconceived ideas. Nobody gets any better, or it's a bit woolly, isn't it? Or but it seems like you've got so much promise.
I was told the same thing, actually.
Yeah, but again, I think I took that fairly good-naturedly, it didn't, because I didn't have any doubts about having a go, and I just wasn't identified in that way. It really wasn't problematic for me, and in terms of experiencing stigma, people have a lot of fantasies about what it is to be a psychiatrist, and a lot of fears about what you might see about them very quickly, or people might want to talk to you about their own psychological difficulties. But again, I have to say I've never felt particularly burdened by that at all. It's always a bit disconcerting when you see somebody slightly afraid of you when you meet them at a dinner party and you say that you're a psychiatrist. People have a lot of opinions about psychiatry as well that they like to share. But again, I mostly find that interesting and stimulating rather than a social problem.
What do you think people's main fears are?
Well, people say, don't they? I mean, it's a cliche. It feels like a New Yorker cartoon, but are you reading my mind right now? But it's like people say that to me all the time. And if only we could read people's minds. What are people afraid of? I think that, to put it quite crassly, I think people are afraid of their own unconscious and the idea that other people who are trained in some sort of way, which, I think psychiatrists sometimes like to do themselves down in some sort of way, but actually they do become very sensitive readers, actually, of people's psyche. And the idea of transference or countertransference from a patient is one that has common parlance in the psychiatric profession. We all think about it and use it, even if we talk about a feel of something, or the patient made me feel this. And one of the skills that we develop in using those is actually a kind of unconscious to unconscious communication that you're able to just do something with. And although we don't operationalize it, we don't like to talk about that because that sounds like a dark thing that we do, it is something that we use. And so I think people are afraid that we will pick up something about themselves that either they don't know or that they're trying to hide. And that we'll, what that will reveal in some sort of way.
Mm-hmm. So there's something about shame, there's something about being afraid of being found out.
Yep.
Like they have some sort of secret that if it were exposed would do them harm in some way.
It must also be the case that, I mean, psychiatry has a checkered history in terms of, I think that you don't need to read very deeply into the history of psychiatry to see some abuses that have been done in the name of psychiatry. And also we do have the ability, very unusually amongst doctors, to section people and to detain them against their will. Now, of course, someone you meet in the street or at a party doesn't really think you're going to do that to them, but it's an extraordinary power for somebody to have. And I think there's something about that that's quite frightening.
Mm-hmm. As a psychiatrist yourself, what do you think a mental health professional should do to keep themselves in check, to, I don't want to say monitor themselves, but like you said, we do have all doctors, all healthcare professionals really have quite a significant degree of power. What do you think, in practical terms, would be a useful course of action to make sure that you use your powers wisely to keep your responsibilities in check?
Mm-hmm. Well, one thing that's very important, of course, is encouraging reflection on that, whether that's reflection on your powers or reflection on what you learn from cases where things have gone wrong, where you can acknowledge, even if they haven't gone wildly wrong, where you didn't make the best decision, actually. Or using the Mental Health Act there, maybe there could have been a less restrictive option. That being said, I think it is very much the case that reflective power is much more relevant. So that reflective capacity, is much more relevant for soft power rather than hard power. Because things like the Mental Health Act, the legislation is set up in such a way that there are a lot of safety nets.
Yeah.
So having to have 3 mental health professionals, having time limits, tribunals, having your paperwork having to be reviewed with the philosophy throughout the whole trust of being the least restrictive option. The practical aspect of no beds ever being available means that, you're always thinking, is there any other way I can do this other than sectioning this person? But the question you're asking is one about power.
Yes.
And within the patient-doctor dynamic, the doctor holds an enormous amount of power. In fact, more power than they really realise. Even if they think about it, it's something that's really hard to get your head around. And I have to say, from my own experience, one of the best ways of addressing that is by being a patient yourself. Because when you're on the other side, whether it's just going to the GP or a specialist about something, or whether it's having your own psychotherapy and becoming a patient in that way, experiencing how vulnerable and how exposed it makes you is an extraordinarily powerful tool. And I think for me, it's definitely something, along with, of course, I speak to other consultants about my cases. I try and keep a list of complicated people, or, complicated cases where I feel like I need a third eye. And without going on at length, I think one other thing is to remember how easy it is to get pulled into something, and that you always need help with your cases. You always need supervision with your cases. You're never so experienced and so great that somebody isn't going to be able to say, well, don't you think you really missed this? Which, when someone points it out, can be so obvious. And we were talking about maturity or experience. And, I think that one of the important things about developing as a doctor is to invite those kind of comments and to use them, and to know that this is this complicated work that we do, and it's about complicated interpersonal relationships. We all fall into this. And so you always need that third eye.
So that willingness to recognize one's own humility in the face of the very, very complex issues that we face on a day-to-day basis.
And that you're always learning.
Yeah.
And that you're human, which means you get pulled into things, and you also get pulled into weird kind of power dynamics.
I've never heard the distinction between soft power and hard power before. Mm-hmm. So obviously hard power would be referring to something more like the use of the Mental Health Act to detain someone against their will in hospital. How would you describe soft power? How does that play out?
Well, I guess it's a bit harder to give a clear description to, but I guess by that I only meant the power dynamics that play out very naturally in the consultation or even in the team, where a consultant's opinion can carry a lot of weight. It can have a force above and beyond just being asked an opinion about something.
Being a consultant has an impact all of its own.
Yeah, or just the way that a consultation can play out between a patient and a doctor, that a power dynamic can be at play in such a way that the patient, I've seen this before, where a patient isn't really able to find a way to say that they don't want to take their medication, and actually they don't really believe that they've got this illness. And the conversation becomes, it's not coercive, not in the true sense of being coercive, it's just compliant, because power encourages a compliant relationship. And it goes back to what we were saying about, well, why people are afraid of psychiatrists. Well, actually, patients also know that you hold a lot of power. You determine whether they get discharged, whether they get referred on to therapy, whether they get sectioned, whether they're on the ward. And people's fantasies about that power are let's use the same word, very powerful. Yeah. And so they get played out in all sorts of ways.
And the way that power might reenact some of their earlier experiences.
Yeah. And I guess by that you mean that power can sort of be traumatizing in some sort of way. I'm sure that's very true. I think there's another side to that, where people who have power can be seen as being very containing as well. That they can say, I'm not worried about you. I think you're doing really well. And yes, I know you're feeling a bit sedated on the medication. I'm totally confident that we can, bring it down. Come and see me in a couple of months. And that there's a way that an anxiety can be contained with somebody that they feel. I mean, we've all had that experience where we've gone and seen somebody who we think, okay, that person really knows what they're talking about. I feel much better now.
So once that power is acknowledged, and once you've done a bit of work to reflect on the power and the different ways I can manifest in the room, to actually the ability to harness it in a constructive way that's actually useful for everyone.
Yeah, well, it's like everything that can have very good effects. It can have very bad effects as well. It has to be used wisely.
And you manage quite a large team.
I do.
How do you find that, and what do you think are the biggest challenges with being a team leader? Because often, I don't think it's actually stressed enough when people are in medical school that, listen, you're not just going to be a doctor, you're going to be a manager of people. Mm-hmm. I think in more modern times, that element is being stressed a bit more, particularly after you graduate and you start to train. But I still don't think it's necessarily made explicit enough early enough. What have you learned sort of in your experience managing a large team and the different sort of obstacles or challenges that you can face in that context?
Yeah, I mean, I'm sure I've learned an awful lot. There are some key things, I think, that I've learned. So, I mean, the team that I manage has sort of very experienced. I mean, of course, I don't really manage them. So they're managed by a team leader. And we probably have about 10 care coordinators of different backgrounds, nurses, occupational therapists, social workers, lots of experience, junior doctors, and myself. But as the consultant, I hold a very particular position because I am the responsible clinician. I am the person who's fundamentally responsible for their care. I won't be the only person, but I will be the person who goes to the coroner's court if anything goes wrong. I will be the person that writes that report. Fundamentally, the buck stops with me. And that gives an interesting dynamic. And I guess a couple of things that I've really learned about managing people is that people have a mixed skill set, and you have to let people find a way to be themselves in the job. You can't demand that people do it the way that you should do it, unless it's really important. You know, sometimes there are some cases where they're really seriously unwell, and this is what needs to happen. You have to learn when to step in and when to step back, because there are many ways to help people, actually, and someone has to make their own relationship with the patient, and for that to become therapeutic, and for something creative to come from that. The other thing that I see my main role being is my job is to absorb anxiety for the team. So again, I mean, our particular team works with very complex, high-risk people who are at quite high risk of suicide, people who engage in an awful lot of self-destructive behaviours, people who have often very aggressive tendencies that they don't fully understand and are risks to other people. Sometimes they're small children. Work that's highly anxiety-provoking. And I think that anxiety can often act to paralyse thinking about the case. I have a way of thinking about this, which is that if you don't help people with the anxiety, they get stuck in a permanent present tense with patients. You know, what we're doing
reactive.
is, we're just managing the risk, but we're not thinking about this kind of hopeful future sense for patients where things can be better, or thinking about, well, okay, let's not talk about the risk, let's not forget about it. But what does this behaviour mean? What's this all about?
So you could think of it as the difference between a coping mentality and a thriving mentality.
Exactly. And I want people in the team to enjoy their work, for it to feel somewhere where that they can think creatively, and particularly not go home and feel paralysed with worry about patients, or feel that they will have to hold that worry alone. Obviously, we risk share throughout the whole team. You know, it would be very sort of bombastic of me to say, and I take all the risk for the team. But I like to think that I very explicitly say, I will absorb this, you know, that I take this on. And, you know, let's not beat around the bush. That's why I get paid more. You know, that's why that's what the trust pay me to do. Obviously, you know, I have a lot of expertise that I bring, yes. Clinical expertise, but actually I'm asked to make some difficult decisions, you know, and take therapeutic risks for people, and that's what I'm paid to do. And I think it's, you know, and again, you're talking about power. It's important that we're clear about who takes that, actually. And that has to be me.
And that being the case, how do you then manage your own anxieties?
Well, I think one learns lots of ways. I mean, there's something about personality, actually, just about people's personalities and what they find easier to absorb. I have noticed that, actually, among people that I went to medical school with. People find the job that suits their personality. You know, some people are more micromanaging or like things to be in a very set way, whereas other people are a bit more broad brushstroke, which is probably more me. And I also, going back to your previous question about keeping check and power, I'm in my own analysis. And I think that that's just been enormously helpful in helping me manage anxiety, think about difficulties managing teams, think about the sort of person that I am or that I want to be. And And, you know, the thing about having a therapist is that, you know, you go and you just give sometimes you just have to go and give the anxiety to them. And
So
then
sometimes
you just
they manage it.
you leave it with them, you know. And then, you know, there's space for me for patients to do the same with me.
Mm-hmm. And I know that you also have a explicit interest in philosophy.
Yes.
You've done a master's in philosophy of mental disorder at King's. And I think, from what I understand, is part of that is to bring more meaningful engagement to your day-to-day job. And then that, I think, that has the dual function of both increasing enthusiasm, but also decreasing anxiety as well. It's like you're better to appreciate the broader context of what you're doing. How do you think about the role of philosophy in mental health?
Yeah, I mean, I think all of that's true. I think I'd always sort of been interested in those sorts of things, and I think I always felt a bit cheated out of having my humanities degree. So when the opportunity to do a philosophy master's came up at King's, I sort of jumped at it. And yeah, I think that mental disorder is so conceptual. You know, even just the idea of what a mind is. I mean, it's a philosophical construct. I mean, you could, you know, psychiatry is sort of, you know, I guess it's a common distinction that neurology manages disorders of the brain and psychiatry manages disorders of the mind. But the mind is like this kind of philosophical construct. And so I was sort of very interested in the way that we think about that, and particularly the contingent ways that we think about that. You know, I think that it's not to say there aren't lots of philosophical challenges in other aspects of medicine, but I do think psychiatry is by far the most philosophically rich, with so many interesting conceptual, ethical, you know, even broader, you know, implications for artificial intelligence and cognitive neuroscience that are all really up for grabs at the moment in the way we think about the mind and the brain and how they interact. Whereas, you know, I don't think, you know, when you look at a leg fracture, you know, like there's the same sort of room for that kind of debate. Whereas, you know, you can get 3 or 4 psychiatrists in a room, and they could all have quite a different formulation of what a depression is, for example, what it's about.
And what makes it tough is they could all be equally valid and all equally useful in different contexts.
Yeah. And so I think that thinking about all these different frameworks and the possibility of different frameworks helps you with managing anxiety or ambiguity, all these things that you have to be able to do and metabolize for your patients actually in the room to help them with that. It helps you do that. I am, you know, following my philosophy masters, I was in New York for a while with a philosopher there, Jerome Wakefield, who he's quite a prominent sort of philosopher of psychiatry. I mean, he's like a philosopher, but he's just very interested in sort of psychiatric issues. But he was very interested in kind of, you know, well, what is a mental disorder? How could we possibly define a mental disorder? And he was very interested in his work having kind of real practical effects in the world. His definition of mental disorder, for example, is the DSM definition of mental disorder. And he wrote an interesting book on this distinction between depression and sort of sadness, actually, just ordinary sadness, and how we formulate those in our lives.
What was the book called?
It's called The Loss of Sadness. You know, I sort of going there was, I don't know if I would quite call it formative, but it was definitely a real privilege to be able to spend time working with him in the way that he thought, and his, not just his enthusiasm and energy, but how he was a proper philosopher and brought this kind of, you know, conceptual thinking. No, I'm not. I've just done like a master's. It got me thinking about how important it is in psychiatry and how useful it is.
Because there's that continuous spectrum between what is a normal function of emotional or psychic life and then what tips over into what we could classify as pathology, which is very, very tricky, and obviously it has to be done to some extent on a case-by-case basis. I suppose there are many scenarios where it's obvious, but for example, you mentioned sadness and depression. There are many cases where it's obvious this is sadness and this is more what we could conceive of as clinical depression. But then there's a vast sort of swath of cases where, to pick apart what's the difference between a normal reaction to one's circumstances and what could be classified as an illness in a medical sense that requires treatment, that sort of has somehow arisen spontaneously out of the ether, it gets very, very difficult.
It's very, very complicated, and it's in many ways a social construct, where that's decided, by the society that we're in, and so this is one of the modern debates, isn't it, about how we pathologise ourselves. We're all very psychiatric literate these days, all very literate in mental health services or mental health symptoms, but I guess there might be a question about things being pathologised that are perhaps part of normal behaviour, and what effect that has on somebody's development or identity or how they relate in the world.
Mm-hmm. Do you worry that in some places psychiatrists have, in the face of that complexity, just kind of swept a lot of it under the rug and just try to be really, really try and treat all of these symptoms as an illness, just like any other kind, just like a physical illness, for example, and really, as a sort of reaction to this complexity, really treat things at the surface level? Do you think that's happened at all within the profession?
Yeah, I think that happens all the time. In a way, it's a defence against anxiety and helplessness, and also a will to help. Psychiatrists are generally people who care and want to make a difference, and it's also, as we said, about one's adherence to different sorts of models as well. So the way that people see the world, in a way, in a way, it's about your philosophical position, actually, about suffering and sadness and families and all sorts of complicated things. And as you say, that doesn't mean if you hold that view that you can't agree on severe pathology. In fact, you'll find psychiatrists agree sort of very well on severe pathology, and we'll all have sort of fairly similar ways of dealing with it. But that's probably about 10 to 15% of what we see, and then there's sort of everything else. Depending.
Do you think you'd be able to briefly describe a philosophical position that you bring to your work based on what you've studied?
Well, I don't know if I could do that, but because I think I've sort of, just taken...
Or what schools of thought, perhaps, have you borrowed from or incorporated into your mindset?
Yeah. So, something that I have become quite interested in is phenomenology. And I set up a phenomenology reading group here that reads sort of Jaspers and Heidegger and some more sort of classic phenomenologists.
What is phenomenology for people who don't know?
That's a very good question. It's quite hard to define. Phenomenology is a lot of things, but it is I think for the purposes of psychiatry, it's the exploration of abnormal subjectivity, which is kind of what we do, actually. And I think that one of the things that attracted me to it is the loss of the subjective. How do you make sense of somebody's subjective experience, which is what they're really asking you to deal with, when the tools that you have feel much more objective, where you might want to do a rating scale, for example, and ask about sort of sleep or appetite, or think about response to medication in a kind of sort of quantitative way. Whereas what's most interesting about psychiatry actually is when the patient brings you a very abnormal subjective experience, whether that's a delusional state or whether that's the idea of a depression being experienced as a complete foreshortening of possible future lives that they can have, that their experience of time has actually just profoundly changed. That how do you incorporate that into the kind of psychiatric models that we have? And I think that phenomenology would teach something about just exploring that abnormal subjective state, being really interested in it. And that doesn't mean that other things get left behind, but I think something that they've struggled with is how you bring those things together. And I think that we've perhaps lost a little bit of that tradition in modern psychiatric training, part of that being because we have very much started to align ourselves with a neuroscientific, quite medical model, or even a sort of maybe biopsychosocial model, but one that perhaps finds it hard to integrate all of those things together in a meaningful way, whereas what the patient is bringing you is an incredibly disturbing subjective experience that they've had.
Do you think that they are irreconcilable, that they are incompatible? The, for example, biopsychosocial model and a more phenomenological way of looking at things?
No, I just think they can become very simplified. So in the same way that phenomenology can quite easily be reduced to just psychopathology, just doing a good mental state, so that you document the kind of things that people are delusional about, or that they have a delusion, that sometimes doesn't promote a kind of just very open exploration of what that is, what it means, how it develops, and different ways in which we might understand that. The same with the biopsychosocial model. You know, it has to be integrated. I mean, it's very hard to do, but it has to be brought together and integrated, rather than, well, there are these factors, and there are these factors, and there are these factors. That can be helpful, but I'm not sure it moves us along a lot. I mean, what it does do, what people like about it, is that it gives some credence to other factors other than just the biological. But I don't know any psychiatrist that doesn't think that. I mean, you don't have to meet very many patients to know that stressful life events and poverty play a role in the kind of difficulties that we see before us.
But it's the integration that I think people might struggle with.
Yeah, and I guess that's what a philosophical model is trying to do, even if it struggles to do it. That's what it's grappling with, something that's going to, you know, pull everything together.
And the other thing about adopting a curious mindset is that it does really serve to improve the relationship you have with the patient, I think, because I think a patient can probably tell the difference between a clinician who's quite curious and quite willing to non-judgmentally, like you said before, bear witness to whatever experiences they have, and then that has a therapeutic benefit all of its own, versus a stance of, let me get the minimum information I need to get in order to do my job to the minimum sort of satisfactory requirement.
Yeah.
I think people can really tell the difference between one position and the other position.
Yeah, and I think there's a possibility of the encounter itself being therapeutic when one takes a more curious stance and allows the patient to bring whatever it is that's on their mind. Or, you know, it can be very interesting what people will tell you if you just give them the space to explore it.
Again, thinking more about different schools of thought, one thing that's very, very controversial nowadays, and what I think has become quite fragmented, is the opinion on things like medication. And I think that's partly because of the nature, the channels through which people get information, I think is very polemic and fragmented. So you get a 30-second soundbite on the news one day on why medication is terrible and a terrible idea, and then maybe a 500-word article a few days later on how actually it's the solution for all our problems. How do you think about something, you know, complex and controversial, like, for example, the use of psychiatric medication?
It's a very complicated topic, and there's certainly, one can have all sorts of thoughts about medication and its usefulness or not. But I guess the question might be, well, how much do I prescribe myself? And I do, obviously I do work with quite a lot of people who are really very ill, but I do prescribe quite a lot of medication. I'm also very sympathetic to the arguments that, put very crudely, that, Big Pharma have infiltrated the way that we think about mental illness, particularly this maybe difference between depression and sadness, or what's ordinary anxiety, in such a way that I think we probably massively overprescribe as a population, and it certainly appears to be the case that despite SSRI prescriptions, I don't know how many hundreds of thousands, millions more there are in Western Europe and North America over the past 25 years. I mean, we can definitely say the population's no happier or less anxious than it was before.
Do you think it's just as much as the case in the UK as the US? Because the US, it's obviously private healthcare is much more the norm, and there's also drug advertising on television, which is quite disturbing. I don't know if you've ever seen adverts where they say, ask your doctor about...
Yes. I mean, I think the US is definitely worse than us. But, I think that I think we still have a sizable number of people who've never seen a psychiatrist, wouldn't need to see a psychiatrist, in primary care on antidepressants. It's definitely the case that lots of people will say antidepressants really made a difference for them. That's important. That's an important thing to take account of. But I suspect, my own personal feeling is that they're overprescribed.
Do you think then that if medication is overprescribed, then that must mean that alternative ways of dealing with one's mental health are underemphasized on some level? Do you think that's the case? I
think that probably is the case, but I think that's it's very complicated.
Yeah.
This is a complex social phenomenon about how we experience ourselves, how we tolerate our own distress, how we think about suffering, and what place it has, where we see if there's any purpose in being anxious at all, or is it always seen as something bad that has to be got rid of and treated. And you can't pick up a newspaper without there being talk about a mental health crisis. And it does seem we do have a mental health crisis actually amongst our university students and our children. And that seems to me to be related to a very complex social phenomenon and not related to underprescribing of, psychiatric drugs. But which leads to the prescribing of psychiatric drugs, which may be, which may be something helpful that we have to offer, but nonetheless doesn't address the underlying cause of it.
There's an increasing school of thought that takes a more evolutionary standpoint, that it's important to be aware that in more modern times, our brains evolved in a certain environment, and the environment which our brains now find ourselves in, and indeed our bodies as well, is increasingly divorced from that. So we're getting more technologically dependent, we're getting more socially isolated, we're finding ourselves separated from the kind of struggle that we would have had to face on a day-to-day basis. For example, if you think about people in a hunter-gatherer community, what their life would have looked like versus life today in a large city like New York or London or something like that. And you could read a lot of, emerging mental health, quote-unquote, epidemics as these manifestations of the fact that we're very much finding ourselves out of our element as human beings, and that we're in these really, really strange environments which our physiology just isn't used to at all.
I mean, I don't know what I think about that. You know, I mean, I'm not sure. I broadly think that evolutionary psychiatry is a bit overemphasized, and you know, there is a little bit of the return to Eden fantasy in there. I mean, I think the hunter-gatherers' lives were probably, you know, despite that, what was that about Homo sapiens? I think it's really quite stressful, actually, being a hunter-gatherer.
But stressful in an importantly different way, you could say.
Maybe, who knows? I mean, who knows what it was like to be a hunter-gatherer?
Yes.
None of us know. But it's also the case that, you know, 100 years ago, or, you know, 150 years ago, you know, people were saying we've had an epidemic of nervous disorders. It's trains, it's electricity. You know, this is you know, this ruining society. And what we are in right now is a period of enormous social change and upheaval. And I think that the internet and social media and the instant connectivity has certainly changed the way that we interact with people, and we are social beings. You know, like this is one of the reasons that I mean, it's very complicated, but that I got a bit interested in Heidegger when we were doing the phenomenology. You know, like we're not just a human being or mind, we're in a world all the time, and that's inseparable from who we are, like our social world and the world that we inhabit. And we now inhabit these quite large social networks. But as you say, maybe sometimes with less contact. And I think that because we're fundamentally very social animals, this is incredibly stressful for us. Mm-hmm. You know, I think people are having quite a focus on it in terms of children, in terms of the use of social media. Mm-hmm. And I'm sure that's right. But, you know, a genie is out of the bottle, and we're going to have to learn how to handle it and how to use it.
Yeah, because the other thing is social media makes everything very explicit and concrete. That's how I see it. So if you think of human beings, you know, like you said, existing in groups, in social networks, and typically human beings are thought of as existing in hierarchies of status, right? And then you get an app like Instagram. What Instagram does is it makes your network extremely large. It makes the hierarchy extremely steep and almost creates unattainable ideals. So you picture a 13-year-old girl who's using Instagram frequently. It's no wonder that she might be prone to a lot of negative emotion if she now finds herself where, you know, 50 years ago, she might have existed in a classroom of 50 or 100 students, and that was her social world.
Yes.
Now her social world is millions of people on Instagram, and on some kind of unconscious level, her social brain is competing with all these other participants.
Yeah, we naturally compare ourselves to other people. That's you know, we are profoundly social animals. That's how we live our lives. Even when we're on our own, we're thinking about other people, how we appear to other people. We have them in our minds. And so there's something really important about that. And there's also something about this idea of how we think about our lives. And do we think about our lives as a brand in some sort of way?
Yeah, like a marketing thing.
Yeah, there's certain values. There's things that perhaps have become subject to a certain almost, if not monetary value, a value of a like or a brand. Things that can't quite be reduced to that. That you know, have effects on our, as we were saying before, our capacity to flourish or to thrive with the skills that we have. Because fundamentally, we're all actually quite ordinary. So some people are amazing, you know, or extraordinary people, but they're very few and far between. But you probably might not, particularly if you're young, pick that up from people's Instagram or social media accounts. And it also promotes the fantasy that other people are happy all the time and are incredibly contented with their lives. And I think there's a gap between what we experience ourselves and how the fantasy of what other people's lives are like.
Mm-hmm. It's like it promotes all of the natural tendencies that our mind already has to make us a bit more unhappy and a bit more neurotic. It amplifies all of those. I think
so. It does. You know, it works so well because it maps onto an existing function, which is our function for social connectivity. Mm-hmm. This is the same with Instagram, for example, or Twitter, or BuzzFeed. You know, people are saying, "Oh my God, it's reducing our concentration spans." You know, but I think fundamentally we all have terrible concentration spans. You have to work quite hard to get your concentration span better. It's probably perfectly attuned. The algorithm probably works to how long we can concentrate on something, and we need something next. But it doesn't help us kind of develop. But at the same time, you know, I mean, I've been a consultant for like 5 years now. You know, I'm getting a bit older. It's very easy for me to be like, oh, social media, the scourge. Mm-hmm. You know, again, that's just...
You're worried, you're concerned that you need to take a balanced perspective.
Yeah, and just, you know, the world's always been full of people like me saying, you know, the thing that teenagers are into is spelling, you know, the end of humanity. But I mean, it's quite an unusual phenomenon, and I think that I'm sure it does a lot of good and like connectivity, but I think that we're going to have to find a way to control it.
Turning more towards things that can make people better rather than things which might worsen people's experiences. You mentioned psychotherapy before. I'm always curious how people describe it, because everyone describes it quite differently. To a layperson, if they had to ask you a question along the lines of, roughly speaking, what is psychotherapy and how could it be of benefit to my life? What would you tell them?
That's a very good question. I mean, I guess very basic, psychotherapy is a talking therapy with somebody who will listen in a very particular sort of way. And when it works well, I guess we might say that therapist takes on a particular role. And that may be that they're placed into a kind of role as a parent, or as somebody who you can project all sorts of things onto from your internal world, and that they can think about and then help you think about in a way that makes sense to you and that doesn't feel intrusive. And I think, I mean, obviously I have an interest in psychoanalysis, so, you know, I'm interested in people's early experiences, and also the unconscious mind in those ways that it will manifest. And I think that the way that people change in psychotherapy is usually through very good attachment relationships.
So you see it as very relational.
Very relational, yeah. Where somebody can think about your mind and the world that you live in and your interpersonal style of relating, and can help you with that. And, you know, it might be that psychotherapy helps you manage your own anxiety better. It might be that it helps you integrate different aspects of your character together, where you find that you can sort of switch between, you know, feeling very paranoid about people to being very quite idealizing of people, that it can help kind of integrate that together. And it can, in its broadest sense, help people move towards some kind of agency. You know, think about the kind of lives that they want to have, and what is it that's holding me back? You know, we all start the year with all of these great New Year's resolutions, you know, and they're all, you know, I'm going to do 500 steps and I'm going to read like a novel every week, and you know, I mean, that's a silly example, really. But
are you talking about self-sabotage?
I'm talking about what gets in the way, you know, of you doing the things that you want to do, and I think a lot of that's unconscious, you know, that it isn't really a question of just trying that little bit harder. You know, what is it that gets in the way? And if you can find a way to talk to somebody about that, somebody who can help you make sense of it, I think there's a sense of freedom that can come with it, and having just that extra bit of freedom in your life, I think, can open up all sorts of possibilities for happiness, whatever that is, and sort of looseness and creativity in one's life, a sense of contentment.
Mm-hmm. So you described quite clearly the relational aspect and how it can serve to create a new kind of functional relationship, perhaps where they had more dysfunctional relationships earlier in their life. And you mentioned an aspect that was more about self-awareness and increasing one's self-awareness, making things which were unconscious conscious, to increase autonomy and agency.
Yeah.
What do you think what kind of person do you think would make a good psychotherapist?
I think that a good psychotherapist is somebody who can really listen, who's curious, who doesn't necessarily jump to conclusions. I think somebody who's led by the patient, actually, and the material that's brought in the room. I think somebody who is able to receive difficult states from a patient and can take them in and do something with them. Somebody who's willing to persevere. Psychotherapy is a long process. Psychoanalysis is a very long process. But even psychotherapy, you know, we find when we give time-limited psychotherapy to our patients that they often feel that they want more. And I understand that, you know, because really we're only just getting started.
And it's rare that people actually have someone to listen to them in their lives.
Yeah.
Like you mentioned listening at the beginning, and I think there almost needs to be there are almost misconceptions people have about listening that need to be cleared up, because I think most people's version of listening is waiting for someone to stop talking so that they can jump in. So they would think of listening as just not talking so much. How do you think about listening?
Well, I mean, when I'm thinking about listening to my patients, I'm thinking about a sort of active listening. So by that, you're, you know, giving your attention to the patient, but you're also allowing yourself to have some kind of free-floating associations that are related to that, so that you can try and help make sense. And I mean, my style is one of just being curious and asking about things, not assuming that I know. And I think that can be experienced as quite intrusive by patients, or even for people who are, you know, have had quite difficult backgrounds or are very sensitive, as a violation, actually, when you tell people things about themselves rather than you ask them and they tell you. And I think that's important.
Mm-hmm. And it's not even, I guess, one of the dangers that has been highlighted in psychotherapy is that it becomes overly intellectual, that they discover things about themselves in a kind of like textbook way.
Yeah.
But what you're really trying to do is get them to have a relational experience.
So, I mean, I guess there's a very strong school of thought that the interpretation doesn't mean anything unless it comes somehow from the patient, but the patient is in the right kind of experiential state to do something with it. We all know that. You know, people can tell us things about ourselves that we sort of vaguely know is true, but we don't experience it in the right sort of way that it can create a possibility for change. It's all about, it's not about the right interpretation. It's about the right interpretation at the right time, and that's a skill.
Because you're not always ready for certain ideas to be internalized.
Yeah, and like all skills, you know, it takes a long time to learn it. So, you know, when you're learning, it's okay to make mistakes, and to, you know, everyone's just trying to do their best, really.
What do you think are the main dangers of being a psychotherapist?
Well, I mean, I think there are all sorts of dangers to being a psychotherapist. I think, one is probably becoming wedded to a very specific school of thought that means that you see certain things everywhere you go, and so, even when the patient says, well, I don't think that I had any sort of abuse or trauma in my childhood, the therapist, well, I don't know, I really think this person's been traumatized and they've sort of forgotten about it or put it out of their minds. And of course that may be true, but of course it may also not be true. I think that there's a danger of a sort of feeling that you have, that if the patient can just do a bit better, that all problems become resistance on the part of the patient, or them not understanding the model properly, or being the wrong fit for your model, rather than sort of perhaps thinking about your own skills or ability, or even the fact that not everyone can use psychotherapy, actually, and it's okay to have a go. And if it doesn't work, well, it doesn't work. You had a go.
Yeah.
I think another danger is seeing everything through a kind of psychotherapeutic lens, that everything has a kind of symbolic meaning, or relates to something else. And of course a lot of things do.
But then you become the psychiatrist people are afraid of at parties.
Yeah, and as Freud famously said, sometimes a cigar is just a cigar. That's, that not everything has to be, interpreted at that level.
Aside from undergoing analysis, are there any things in particular that you do day to day to look after your own mental health or physical health?
Well, I don't have any time, after I've been to analysis and come to work. Yes, I love to read. I like to go to the theatre. I have my relationships, my personal life, my family. I like to cycle. All these, actually, what? I love cycling. I sometimes worry that I free associate better on my bicycle than I do when I'm lying on the couch. There's something about cycling where there's a kind of mechanical aspect as you kind of cycle through the city, and you can kind of allow your brain to roam free in some sort of way. But I don't like to say it's like dreaming. That makes it sound like I'm very dangerous,
It's a bit like dreaming, though.
But, and there's something I find almost meditative about it. In the same way, swimming has a similar kind of thing. So I do things like that, but there's also a reality to there is only so much time.
Yeah.
Yeah.
Yeah, I think something about engaging one part of your brain, like you said, in a very mechanical way, just allows another part of your brain that perhaps is always tied down to just relax and open up and, like you said, free associate and maybe produce some useful things from there.
Yeah.
I ask my guests to, after I ask them loads of questions, to ask me a question if they want to, if they're particularly curious. Do you have any questions that a consultant psychiatrist might want to ask a training psychiatrist?
I might be interested if you think that you could see yourself as a consultant psychiatrist doing the sort of job that I do.
That's an interesting question. It was really, I've worked similar jobs. So, to put it in context, so you manage an outpatient team that manages people with mood disorders, anxiety disorders, personality difficulties, things along those lines. Having worked maybe 6 or 7 different psychiatric jobs now and a few medical jobs before that, what I've noticed about myself is, rather than the specific context that I'm working in, what matters most is who I'm working with and the team. And I tend to make quite a broad distinction between a team that is functional and a team that is terribly dysfunctional.
Yeah.
Like, does it work? Like you said, what you described before is, there's a very explicit hierarchy. And one of the functions of that hierarchy is to allow anxiety to be dissipated appropriately, for example. But, it serves all sorts of functions and sometimes way more concrete, way more practical functions as well. So, to the extent that I could find a team that is functional, I would say it's almost irrelevant what the patient group is or what the specific circumstances are. So I guess my answer is probably yes.
Good.
But with some caveats.
Yes.
I have one major caveat, which is what I worry is that all of psychiatric expertise in secondary care is necessarily being diverted to all of the most severe cases, which makes sense because when there's a resource problem, it makes sense to prioritize patients in that respect.
Yeah.
But on a societal level, I worry that as a result, you have a large group of patients who are being managed, for example, by GPs. And there's nothing wrong with that, essentially, because, GPs would have an element of psychiatric training. They're competent. But you wonder what could happen on a mass sort of societal level if you could disseminate psychiatric expertise more widely. And I think it is the case that you can really, with people who are like moderately functional, you can make a really big impact with a lot less resources than someone who is at the very, very low end of sort of the functional spectrum, if you like. Obviously, everyone needs treatment, but I think both even for the individual clinician to have a variety of different experience, it's really nice to be able to treat a variety of different patients and not patients who are just at the most severe end.
Well, that's interesting. I mean, I agree with you to some extent, actually, about the severity issue. Because often a lot of resources are going into people who are very unwell, but it can be hard to know what to do that can really help them recover. Whereas perhaps I don't really want to get into an either or, but when resources are put into, say, young people, that might potentially transform a life and prevent them getting into a situation where they become very sort of long-term and chronic users of mental health services. I do also worry that psychiatry has a tendency to overestimate what it has to offer, and that these sorts of difficulties emerge from the social, economic and political climate that we're in. And so, for example, I do wonder if perhaps smaller class sizes, just putting the money into actually, quite small primary school classes where teachers can provide have enough space and literally emotional space to be proxy parents for children who perhaps don't have that at home. I think children are, not all children, but many children are resilient in all sorts of ways and actually can do a lot with little. And that those kind of interventions might have a much bigger impact. Or, for example, getting people with chronic psychotic disorders into some sort of work. Whatever that is, that's really kind of promoted and helped for people to stay in that in all sorts of flexible ways, in ways that they can manage. That these sorts of things might have really enormous impacts.
Yeah, I think that obviously makes a lot of sense as well.
Yeah.
Well, thank you very much for your time.
It's my pleasure.
Very interesting. And I'd like to do this again at some point in the future.
You are listening to the Thinking Mind podcast.
If you enjoyed today's podcast, we'd love it if you share it with a friend, or you could give us a rating on Apple Podcasts, Spotify, or wherever you listen. If you fancy it, you can even buy us a coffee to support the team, and the links for that will be in the show notes. Thanks for listening.